But what we've also done over the last 5 years is try and create standards. And if we can create standards, we can think about implementing them, which is what we're going to be doing for the rest of the afternoon. And it was wonderful to hear how this report was created. And one of the things we wanted to do was try and address one of the recommendations of the IMMDS, and hidden in amongst it is this one here, 2.22, which says that we should go about developing a core set of information, which is designed both by patients and clinicians to help people understand the process of surgical innovation. Now, a core set of information represents baseline information that's used to catalyse further discussions. So it's not meant to be a tick box exercise. We know that all patients want slightly different information. Some might want a lot of information, others not so much. But what we need to do from the beginning is to demonstrate that we offer the range of information that people might want, and then dive down into specifics as required and tailored to people's needs. And we've already heard a little bit about this idea of shared decision making, and I'm going to explain a bit about how we think a core information set would fit in with a clinical discussion. And this slide here represents quite a widely used model of how we make medical decisions through this process called shared decision making. And in this model, shared decision making involves the introduction that there's a choice. People need to know that there's a choice coming. And then that's followed by discussions about options that become increasingly tailored as the doctor and the patient learn more about each other. And that's based on the patient's individual values and preferences. And finally, the planning and actioning of that decision. And all the while, there's ongoing checking of preferences and supporting the decision-making process. And of course, this is not a single event. This exists as a continuum throughout someone's patient journey and constantly evolves and changes over that time period, and it never stops. So we think that core information sets sit about here, at the base of this triangle. So they support the initial option presentation, which you then use to hone in on the bits that are important. We set about making standards with this sort of scope. So we were UK-centric rather than international. We were interested mostly in adults with capacity, so people able to make their own decisions, for any new treatment or device or implant in either the planned elective setting or in the emergency setting. And we most wanted to describe what we talk about, but it wasn't really within scope to talk about how we do that. And this was going to be just the essential information. Of course, people can have as much information as they want. And this is how we developed it. We started by collecting lots of source documents. And then a team of us went through line by line to pick out all the information we could talk to patients about. And then we organised that information into main themes, and that turned into a draft core information set. At that point, we had extensive discussions with patients and professional stakeholders where that was refined into a final set. And these are all the documents that we used. Hundreds of published studies, hospital policy and guidance documents, and we also analysed the wonderfully rich data collected by the Lotus team with interviews with patients and professionals and recorded consultations. And these are all boiled down to these 7 key information themes. A lot of these are fairly unique to surgical innovation. We've got details of the new procedure, conflicts of interest, reasons for the innovation, unknowns, choice of treatment alternatives, expertise with the innovation and governance issues. And I'm going to go through what we found with each of those in a little bit of detail. And unlike Jane, I'm not going to be using a sort of warning system. I've gone for a completely different example that I hope involves no gory photos. So imagine you've asked me to write a paper or an article. And I've got this new innovation, a laptop, that I want to use instead of my trusty typewriter. Now the first thing I need to do is tell you that this is new. And you may want to talk more about these things. So what part of it is new? Well, it still types letters, but it's electronic and it doesn't use ink. It's new because I've not used a laptop much before, but there's plenty of people around using them to write papers and articles. Actually, it's quite a big change. A laptop is quite far advanced compared to a typewriter, and it seems to do a lot of other things other than just typing. You may also want to know why I'm suggesting this innovation. And we might divide these things up into things you might want to know before I've written the paper, and also things after I've written the paper. So this laptop, I think it's going to be faster, clearer, easier, but there's a risk it might run out of batteries. I think this innovation is appropriate for you because we're on a deadline and I want to email you the paper later, and I can't do that with a typewriter. Now, after I've written the paper, I can tell you actually it was much faster and it didn't run out of batteries. The trouble was I had to keep it plugged in the whole time. Now, it was so great, I think we should use this for all the papers that I write, in every situation. Now, of course, there are alternatives to using a laptop. And I've been writing papers by hand for many years now. It's slow, but it is tried and tested, and it's the way of writing papers that's really the gold standard. Of course, if you don't like that option, we could always not write the paper at all, and that might be the right choice for you. So let's imagine we've agreed to use this laptop. Okay, so catastrophe. This is completely unexpected. This has never happened to my typewriter, ever. I didn't even know it could. And it's certainly never happened with my pen and paper. And joking aside, unknowns are a really important and unique part of surgical innovation. It gets to the heart of why something is new, because we don't know things about it. And we should be clear with people before surgery that there are unknowns and try and explain how much uncertainty there is based on the evidence we have and professional opinion. We should also be honest that if unexpected things happen, we may have to modify, stop, or change to an alternative procedure. And of course, after surgery, we need to feed back and explain if we did modify, stop, or change to another procedure, and discuss any unexpected benefits, harms, or consequences that actually did happen. So returning to our example, my laptop crashed. I couldn't get it working again, so I had to abandon it. I had to write the rest of the paper by hand, and as a result, it is a day late. The next thing I want to talk about is expertise with the innovation. Now, I couldn't believe I found this, but if you look really closely, this is actual footage of me learning to use a laptop. And my skill with the laptop is not the same as a typewriter, but I have done several training courses, and I have someone from tech support who's going to be sitting next to me while I write the paper in case it crashes. I have written 5 papers on a laptop before, but I've also written 300 papers in general, so I'm pretty good at writing papers, but not so much at using this technology. I should probably say that I did help develop the laptop, and I have quite a lot riding on its success. But for surgical innovation, it is worth bearing in mind that conflicts of interest do extend beyond financial, and James touched on this, and other people have touched on this. Probably in the UK, reputational or emotional conflicts of interest are possibly more important than the financial ones. So we tend to think of it financial, but it isn't necessarily. Finally, I want to say that I'm going to be using my laptop in a safe space, with all the correct approvals and oversights. Issues of good governance came out quite strongly in our research. I think we've heard that again today already. People wanted to know if the procedure was approved for use, how safety was being monitored, and what would happen if something were to go wrong. So those are our information standards. And at the moment, we have launched this out to a public consultation. That consultation is still open. I would really welcome anyone to complete it if they haven't done so already and pass this around to people who haven't. So we asked people how important they felt each of our core information set items were on a scale of 1 to 9. So far we've got 62 responses. 2/3 of those were from patients and members of the public, and 3/4 of them were women. Most patients had surgery within 5 years, and 14 knew that they had an innovative procedure. We also had a range of professional backgrounds, lots of different surgical specialties. And what we found was, in general, a lot of support for the core information set items. Some slightly more, but slightly less, but typically we view a 7 and above as being really very important. And I just want to leave you with one thought, that when we compare the results between patients and professionals, we're starting to see some interesting changes. For a start, the patients think that all of them are more important than professionals, but also some of the issues, perhaps the thornier ones around governance or expertise, these sorts of things, patients think are slightly more important than professionals. So in conclusion, we have used robust methods to develop standards of information for surgical innovation. What we need to do now is figure out how to implement this within the NHS. And that's what I hope to do for the rest of today. Thank you very much.